Good afternoon. My name is Wes Bolge. I'm from the University of Florida. I'm the first of three speakers for this Joint Therapy Diagnostic Symposium at the AAPM Spring Clinical Meeting in 2021. The first talk that we'll provide in this series is looking at dosimetry methodologies and nomenclature for calculating patient doses in radiopharmaceutical therapy. We'll start with the general schema provided by the MIRD Committee of the Society of Nuclear Medicine, and then we'll close in the second half of my presentation. We'll talk about a new ICRU report, specifically focusing on dosimetry-based and guided treatment planning for radiopharmaceutical dosimetry. So before we begin, we understand that radiation absorbed dose to internal organs in the patient from the administration of a radiopharmaceutical, either in diagnostic or therapy, is not directly measurable, so it has to be computed. And to do this, we have to have a mathematical dosimetry formalism to do that computation, which typically includes a combination of pre-computed quantities as well as patient-specific data via direct measurement on the patient. So the original methods and models, equations, and nuclear decay data needed to do this were really pioneered by the MIRD Committee in the early 1960s. The most recent revision of the MIRD schema that we're currently under was published as MIRD Pamphlet 21 in the Journal of Nuclear Medicine in 2009. And I'm very pleased to announce that after several years of very hard work, we have a very comprehensive MIRD primer called the MIRD Primer 2020, a complete guide to radiopharmaceutical dosimetry, and this should be coming out very soon in the next couple of months. Before we move on, I want to mention that internal dose calculations are also of interest in the radiological protection area. In fact, many of the key members that developed the MIRD schema also had membership in the ICRP at this time, in the 60s and early 70s. But very soon, the ICRP kind of diverged from the MIRD schema, and they developed their own terminology, expressions, quantities for radiological protection for internal emitters. I'm pleased to announce that after MIRD Pamphlet 21 came out, there was a lot of work within the ICRP to harmonize the system. And so with publication 130 in 2015 and 133 in 2016, there is now a near perfect harmonization of how you do an internal dose calculation, either in the context of nuclear medicine, MIRD, or in radiological protection, ICRP. So let's begin. So if we start with the MIRD schema looking at the mean absorbed dose rate, we can define this as the mean energy imparted to a target tissue, a tissue in the region or a region in the body for which we wish dose estimates per unit mass, the rate at which that absorbed dose is delivered within a patient from a pharmaceutical distributed uniformly within source tissues at a time t is given by this expression. So the source tissue is where the radiopharmaceutical localizes. The target region or tissue is to which we wish to assess the dose. So the A of t is the time-dependent activity of the radiopharmaceutical in the source tissue. The S value is another quantity that is multiplied by that activity to get us a dose rate. So the first thing we note is the summation is over all possible source regions that may contribute to the absorbed dose to the target region. So for very short-range radiations, the relevant source region may only be the target region itself. For source regions that emit photons, gamma rays or X-rays, or potentially bremsstrahlin photons coming from emitted beta particles, the relevant source region may be adjacent to or even distant from the target, and may also include the target itself. The time-dependent activity depends on the rate, represents the rate of nuclear decays in the source tissue at time t, and the S value represents the absorbed dose rate to the target tissue R sub t per radionuclide activity in the source region, also at that same time. And here, for convenience, time is usually measured post-administration of the radiopharmaceutical. So in that previous equation, the absorbed dose to the target tissue R sub t is shown to be given as the sum of the product of the two terms. So that first term is the source activity as a function of time, and then the radionuclide S value. So clearly the first parameter is time dependent. The second may, in general, be considered not to vary with time for most applications. A good exception to that rule would be looking at tumor dosimetry. During the course of radiation delivery to the tumor may change in size. So the corresponding expression for the mean absorbed dose would be the time integral of the absorbed dose rate, given by this expression, the sum over the source regions, A tilde times the radionuclide S value. So A tilde is that time integration of the activity as a function of time. And we call that the time integrated activity, or TIA. So the time integrated activity really represents the total number of radionuclide decays in the source organ. So take the liver, for example. You have A0 administered activity circulated in blood. A certain fraction of that is taken up by the liver parenchyma. So now you have activity in the liver tissue itself, which then decays by physical decay, as well as activity could decrease as a function of time due to metabolic elimination of that radiopharmaceutical in the liver. So to do dosimetry, we have to do serial imaging, time serial imaging. We can't just, unlike most diagnostic applications in nuclear medicine, where a single image post-administration is sufficient for the diagnosis. To do dosimetry, we need we need to know what the time course history of activity in the source region. So here's an example of 1, 2, 3, 4, 5, 6, 7 different time points in which I have activity as a function of time. The y-axis here is fraction, so you can think of this as the fraction of administered activity or the fraction of activity initially taken up by the organ of interest. So you see the expression for the time integrated activity. If I then multiply through by A0, the administered activity, then I'm integrating a fraction, and we call that small a tilde, or the time integrated activity coefficient. In the earlier variations of the MIRD schema, that had been referred to as the residence time. So to do the analysis, the first thing you need to do is you need to collect the data, organize the data, scale the data, and then fit the data. So here's from the MIRD Primer 2020, several options for functional fits to that data. A lot of cases we rely on exponential terms that look at the washout of the activity from the organ, as well as the wash-in, the rise from zero. At that point, then we need to time integrate, and so I can do this by multiple ways. The most simple way is simply just to break your function into a set of trapezoids, and then just use plain geometric equations to look at the area of each trapezoid, and then you just linearly sum. So the area under this curve would give you that time integrated activity coefficient. Looking at the radionuclide S value, so this is a characteristic of the radionuclide and the anatomic model used to represent the internal anatomy of your patient. In the vast majority of cases historically, especially for diagnostic, we use what are called reference anatomical models to compute what this S value is. And so they're again borrowed from radiological protection. You have a series of essentially 50th percentile patients at the newborn, 1 year, 5 year, 10 year, 15 year, and adult, male and female. And this is used for, these computational phantoms have been used for many years in different formats. Early formats were a stylized or mathematical representation of body morphometry, internal organs, and now we've moved to voxel-based reference phantoms, and then most recently to polygon mesh-based phantoms. The radionuclide S value is given by this equation, so you can see it immediately. You need a decay scheme. You need the energies and yields of all the different radiation components from the radionuclide. And this small phi is what we call the absorbed fraction. What fraction of emitted energy in the source region is deposited in the target region per emission of that type. So the summation over I is over the different components of the radionuclide decay scheme. And then to calculate dose, we then need to divide by the mass of the target region. If I then multiply through by 1 over m, the small phi becomes a capital phi, and we call that a specific absorbed fraction, and has units of per kilogram. We don't, moving forward, especially for therapy applications, we are now getting to the point where we don't have to fully rely on reference phantoms. We can use more patient-specific phantoms. And so this is a paper that is coming out in the journal Medical Physics, in which patient-specific CT contours were used and a polygon mesh reference phantom, and then using either rigid registration or deformable registration, you can essentially merge the fully segmented polygon mesh reference phantom to the internal and external anatomy of the real patient. And then using radiation transport simulations, you can calculate S values that are much more individualized to the patient than using reference phantoms. The MIRD schema can be applied at multiple scales. Obviously, we can have whole organs. Whole essential organs can be sources and targets. You could have suborgan regions. In the case of the kidney, you can separate the renal cortex from the renal medulla. Image voxels could be declared to be source and target regions. You can have PET and CT and PET CT, SPECT CT. The individual voxels can be defined as source and target regions. And then you can even carry this down to computational models of individual cells and cell clusters as representing sources and targets. So the MIRD schema is very dynamic. You get to pick what the source and target regions are. One typical issue is that many people associate the MIRD schema with whole organs, and that's absolutely not the case. You get to define with the MIRD schema what your source and targets are. Your goal then is to come up with what the specific absorbed fractions and therefore the radionuclide S values are for that level of anatomy. But here's a very important point. Now, regardless of the spatial scale, an implicit assumption of the MIRD schema is that the radiopharmaceutical is uniformly distributed in the source organs, source regions, and dose is uniformly average over the target regions. So that is always the case, but you get to pick the anatomical dimensions of R sub S and R sub T. One extension that was pioneered by Rob Hobbs, our next speaker in the series, was for alpha radiopharmaceutical therapy. Here he was looking at the kidneys and really coming to the realization that macroscopic models of the kidney really weren't sufficient, appropriate to looking at renal damage delivered by alpha particles. Really, looking at the range of alpha particles, you really needed to go down to the individual nephron level. And so here a stylized model of the nephron, including a glomerulus in a simulated segment of a proximal tubule, is used for source and target. And so the MIRD schema in this case, instead of source region and target region, we define source compartment and target compartment, which are really anatomic microscopic regions of the organ. In this case, for example, the source compartment could be proximal tubules, the target compartment could be the glomerulus. A tilde is what we've defined before. That's the time integrated activity that is measured in the RPT patient, essentially imaging the radiopharmaceutical activity in the kidney as a whole. You then need S values down at the level of the nephron. So we call these microscale S values, and they're computed using the geometric models shown here on the right. And then the link between what we can measure and what we need to apply the S value is what we call the time integrated activity apportionment factor. So this is essentially what fraction of the activity that is measurable is localized at the microscopic level, and that obviously has to be gleaned from preclinical animal models where we can measure these things ex vivo. Before we leave MIRD, I would like to make a quick pitch. The MIRD committee is now really focusing on software, and through 2 NIH grants, an NIBIB grant between the University of Florida and Memorial Sloan Kettering, and also a grant by Roger Howell from NCI within Rutgers, we've developed two software, MIRD-Calc, which provides phantom-based nuclear medicine dosimetry, and MIRD-Cell, which applies the MIRD schema down at the level of cell. We're working on also MIRD-CT to allow us to do CT-based doses across a range of computational phantoms, and a curve-fitting component that would be an integral part of MIRD-Calc called MIRD-Fit. These are the MIRD-Calc and MIRD-Cell, or soon to be, MIRD-Cell has been launched, MIRD-Calc will be launched soon, MIRD-CT and MIRD-Fit will come within the next year or so. So let's move on to ICRU. So ICRU has issued guidance in the field of radiotherapy for some time now. So way back in September 1993, Report 50 came out, which essentially gave a roadmap of how you would do three-dimensional radiotherapy treatment planning for photon radiotherapy, what is called conformal radiotherapy. And a key feature of this report was all these various volume definitions: gross tumor volume, clinical target volume, treated volume, irradiated volume. So the challenge is, when you go to radiopharmaceutical therapy, what are the corresponding volumes? Can we adopt these terms, or do we have to invent a similar but distinct nomenclature for doing dosimetry in radiopharmaceutical therapy? So the ICRU continued, so a later updated report in photons in 1999, electrons in 2004, protons, IMRT, brachytherapy, small photon fields, light ion beams, all the way up to 2019. And so the three of us in this symposium have been very fortunate to be part of an ICRU report that is now going to address specifically radiopharmaceutical therapy. So this is Report Committee 31, which will issue this report. That will come out hopefully in 2021, if not early 2022. This is the content of that report. There's 4 clinical examples that are given in the back, along with extensive references. I'm just going to, in this limited time that we have, I'm going to just briefly talk about chapters 5, 12, and 13. So, conceptual framework for RPT patient dosimetry in this new ICRU report makes the general principles. Unlike systemic cancer therapies, in general, the use of radioactively labeled pharmaceuticals results in not only molecularly targeted internal radiotherapy, but also the possibility for imaging and measuring the pharmacokinetics of that pharmaceutical. So in case of prospective or pre-therapeutic imaging or measurement, it's possible by use of pre-therapeutic dosage of the same pharmaceutical or surrogate via a theranostic companion drug. A good example would be yttrium-90 labeled therapy, and we do the biokinetics by labeling with indium-111. Pre-therapy and within-therapy imaging and measurements opens the possibilities for patient-specific absorbed dose planning and verification, which is common practice for other radiotherapy modalities. So, looking at this region and volume nomenclature between previous ICRU reports and external beam, and then this report, you have the patient representation, CT planning image, for example, and then terminology for radiated tissues, such as the irradiated volume. So the committee has been trying our best to try to provide a one-to-one analogy or a nomenclature that is roughly consistent with what is done with other forms of radiotherapy. So we define localization region, organs, tissues, cells in which radioactive compound localizes. A source region, we've seen that before. Organs and tissues in which activity content is a function of time, and time-integrated activity are estimated. And these can be either delineable or non-delineable, depending on the possibility of performing patient-specific imaging estimates in the level of uncertainty in the doses. In the traditional radiotherapy series of the ICRU reports, we have the gross tumor volume, the clinical target volume, planning target volume, and irradiated internal target volume. In our report, we define the clinical treatment regions to treat, including macroscopic disease and microscopic disease, total disease burden with margins for delineation of uncertainties. We define the DTR, dosimetric treatment region, for which the mass and absorbed dose are estimated. The DTR is a subcategory of the CTR. DTR is also can be specified as delineable or non-delineable, depending on the possibility to perform patient-specific estimates and the level of uncertainty. A region of disease included in the source region is generally also included in the dosimetric treatment region. And finally, we have organs at risk and remaining volume at risk within the standard radiotherapy series of ICRU. In our report, we define the region at risk, RAR, critical tissues that, if irradiated, would suffer significant morbidity and functional loss, and for which the mass and absorbed doses are estimated. There again, we can divide the RAR into delineable and non-delineable regions. We also define the RAR-SE, the irradiated body regions for which absorbed dose estimates may be useful for estimating long-term risk of stochastic effects, such as secondary cancers. Normal tissues included in the source region are generally included in all these RARs. Just a quick little example, if you look at lutetium-177 dotatate, we can look at this particular example. So the clinical treatment region would be the neuroendocrine tumors. Localization regions would be those regions that accumulate the agent by expression of somatostatin receptors and by other mechanisms, including tumors, livers, kidney, spleen, small intestine, potentially pituitary gland, salivary gland, and thyroid. And then here you see the list of source regions, delineable, non-delineable, dosimetric treatment regions, delineable, non-delineable, and the regions at risk, delineable and non-delineable, as well as stochastic, for stochastic effects. In Chapter 12, so a common theme through all these radiotherapy ICRU reports is prescribing, recording, and reporting. So general principles as per previous ICRU reports, there are 3 reporting levels identified for RPT. The requirements to achieve a given level depend on the pharmaceutical and the therapeutic indication. Treating physicians and patients alike should seek the highest level that can be achieved within their constraints. So consistent, these are not just definitions for this report, but for all forms of radiotherapy. Level 1 are minimum standards for prescribing and reporting. Below these standards, any form of radiopharmaceutical therapy should not be performed. Level 2, which is what you want to aspire to, is applies for prescribing and reporting state-of-the-art techniques, so that the calculation of patient-specific is patient-specific and that it meets pre-specified uncertainty criteria. A complete quality assurance program is used to ensure that the prescribed treatment is accurately delivered. This translates into collecting data required to calculate absorbed dose to DTR and RAR. Depending upon the agent, clinical circumstances, and ability to accurately collect the needed data, this level should include adjustments to the prescribed activity based on absorbed dose to these regions. So there again, you're moving away from fixed activity to a dose-based approach. And then level 3 is really beyond state-of-the-art. It's essentially at the research realm, novel developments. They're used for development of new techniques and approaches for which reporting criteria are not yet standardized by the ICRU. The objective here is to develop and implement new techniques that may be implemented and refined in clinical trials to evaluate their applicability for widespread deployment as level 2 recommendations. So as research forms of dosimetry advance, it's at one point level 2 becomes level 1, and the old level 3 becomes the new level 2, and you continue with new level 3. So that is the hope. So here's just one of many examples given for this example of lutetium-177 dotatate. We have the treatment indication, posology, the L1, L2, and L3. So you can see L1 administered activity and amino acid is given per package insert. Level 2, you would calculate doses to lesions as well as to the regions at risk. And maybe even level 3 is you're calculating tumor control probabilities and normal tissue complication probabilities and optimizing them. And then you can see the different levels for prospective dosimetry pre-treatment, verification dosimetry post-treatment, and then what the treatment driving quantities are. So for L1, it's nothing, really. L2, you're looking at trying to avoid kidney toxicity, marrow toxicity. In level 3, you would actually be, like other forms of radiotherapy, trying to deliver a certain tumor dose. So finally, future areas of study. So absorbed dose-driven implementation of treatment planning in RPT, as outlined in the report, will be adopted only if such treatment planning is shown to provide long-term survival advantage over more expedient approaches to adopting a chemotherapy dosing paradigm, essentially fixed-based activity. To date, studies demonstrating the advantages of dosimetry in treatment planning in RPT have not been conducted with the level of rigor and transparency required to change practice. So therefore, we need to standardize and well-validate quantitative imaging and dosimetry techniques, and that'll be addressed by our next speakers. Methods that reduce the logistical burden on patients and that are easy to implement while also preserving accuracy, and reporting that includes assessment of the accuracy of the calculation, providing standard deviations on the reported doses. One key feature of the MIRD calc program that is being released by the MIRD committee is propagation of error through the system. And then finally, the following additional areas are important for future progress in the field, especially for alpha-emitting radiopharmaceutical therapies. And these include research to better elucidate the relationship between absorbed dose and non-uniformity at the microscale in biological effect for both normal tissues and tumors, and then also bioeffect modeling that incorporates non-uniformity at the microscale, dose rate effects, and for alphas, high LET effects. So with that, I'll close my presentation and see if you have any questions. Thank you very much.